Hey, everybody, Doc Parsley here for the daily COVID powwow. Uh, this is day 1,968,482 of the lockdown. I'm sorry, the shelter in place. There's nothing requiring us to be home other than threats. Um, so I wanted to cover a few things today, what's heavily on my mind. One, in case you haven't already heard, which I think probably haven't, but things are actually looking better. Things are going well. So we're screen sharing. Let me pull this up. Let me screen share this. So we'll go back to my favorite site here, Worldometers. Actually, let's go up. Let's do this little exercise that we like to do every day. So we have world population. We have total deaths, 16.8 million people, 110,000 deaths today. All right, let's keep all of that in mind. Let's keep things relative. All right, so 16.8 million deaths since January 1st. We now have 125,000 deaths worldwide, and that's before the January 1st. That goes all the way back to December. I think China's first death was maybe November, definitely December, the latest. So we have 125, 896, almost 126, and 16. Oh, can't put a point. I did that last time. 16, 8. So 125,000 deaths divided by 16,800,000. So we are at a 0.7% since January 1st, worst case scenario. We are at 0.7%, meaning a 99 of everybody who's died since January 1st, there's a 99.3% chance that they have died from something other than coronavirus. We take risk every day. Part of being alive, part of living means taking risks. We take risks driving our cars. We take risks going in airplanes. We take risks walking down the street. We take risk all the time. So let's keep that relative. Now, back to coronavirus. This is actually held really steady. There seems to be a change with this active cases. It seems for the last 3, maybe 4 days, this has been 96 instead of 95. Makes the math easier if we say 95%. So just to reinforce what I keep saying, we don't have 1.9, almost 2 million active cases. What we have is 1.990 total positive tests. As far as active cases, we have slightly under 1.4 million infected patients, meaning that's people who have had a positive test. Out of that, 95%, or, look at that number, 1.397 to 1.36. Like that's the difference right there. In serious, in the total cases and serious cases, right? It's only 50,000 out of 1.4 million. That's pretty amazing, right? Germany's data is showing a death rate of about 0.3. They've done really well at testing early and tracing contacts, which is the epidemiologic word for or phrase for finding everybody who test positive and seeing how many people they've interacted with and quarantining them early, and then testing all of their contacts to see how much this is spreading. So they have a much better idea of who all has cases than we do. There's some data out there that there might be 30 to 50% of the population that already has antibodies to this. We can talk about what that means in a minute. So if that is the case, we don't have a very good idea what our death rate is, because we don't know how many people have it. If it's 30 to 50% people who have already had it in America, or at least in metropolitan areas, that could be orders of magnitude different than what we think the current death rate is, or case count would be orders of magnitude different, which would change the death rate significantly, the CFR. So go back to this. We basically have 5%. We'll call it 5% to make it easy. 20% death rate amongst serious cases. You can't be over here if you're not a serious case. Nobody from a mild case dies, and if they do, that's a super, super rare thing, because they're most likely, if they've been tested, they're most likely going to seek medical care and go back into medical care and end up in the serious cases and be tracked. But anyway, so essentially one out of every 5 out of this group. So again, this is today's data. We're throwing up a number over 2,000 a day. If you look at yesterday, we were significantly under 2,000. It looks like 2,000 is going to be roughly our peak. Of course, people don't die according to a clock, and the numbers aren't recorded according to a clock. So there's some delay. How many people are actually dying over the 24 hours is not exact, but we can say approximately. But here's what I'd like to point out to you again. So let's look back at yesterday. Yesterday, we added 26,000 new cases, right? New cases, meaning we've tested somebody, they've proven to have it. We out of the 586,000 people we have that have positive tests, we had 1,500 deaths and 12,772 serious and critical cases. That's yesterday. All right, remember that, 12,772. Now we go to today. We're up to 610,000. Well, let me go back and share this one. So total tests, we were at 2.9 million yesterday. Total tests a day, we're slightly over 3 million. So we have added new cases. We've added 23,000. Now, if you remember, I told you this was 12,772. So what we're looking at here is less than 700 new cases out of 23,000 new cases are actually serious. If we're only going up 700 a day, 1 out of every 5 people of those are going to die on average. This number can't possibly be going up. This could not possibly be going in a bad direction right now. Now, again, I'm not saying that this is insignificant. Of course, this is a large number of people. I don't want anyone to die. I'm not being glib or dismissive. What I'm saying is that people are already going to die from lots of things, and this is not a statistically significant change. If we click on the U.S., what we see, New York, of course, leading. Yesterday they had 671. Today they already have 778. The total deaths, I mean, that fits very closely with the new deaths. The total deaths, 10,000. So, I mean, we've had 25,000 deaths. Almost half of those have been in New York. Everybody else not gaining super quickly. This is my state down here. Texas, we have a very large population. And, we have not had our peak yet, assuming we are going to have our peak, which we almost certainly will. But 318 total deaths, 23 deaths today. Yesterday, what did we have? 17 total new deaths yesterday. So this is all good news. Of course, this isn't an insignificant number of people, right? 2,000 people, that's not insignificant, but it's going in the right direction. So let's talk about what I mean by it's going in the right direction. What I mean by it's going in the right direction is that the modeling came out when this first started and said, based on factors that we didn't have a lot of control over. So there's a high heterogeneous policy. There's a high there's a lot. Let me say it this way: there's a large variation in how countries are testing around the world. So not everybody is using the exact same test. Not everybody is testing under the same conditions. There's something called a severity bias, meaning that if you are tested, you're more likely to have a positive test. That was another thing I wanted to bring up from this data that I skipped over. The positive test rate, meaning for every test we give, what percentage of those actually turn out to be a positive test. The positive test rate is not super high right now. I wanted to say I figured it out yesterday to where, it was only about 10%. And that is, of course, people who are sick enough to go seek medical treatment and get tested. So that means that there are a lot more people that have it than what we're aware of. And so the testing isn't super helpful yet. It's getting more helpful. The larger the numbers, the more people we test, more people other countries test. Some people who tested a lot earlier, who quarantined and isolated earlier, they're feeding some data. But the models that we started with, I want to say, were somewhere, at the very beginning, maybe February 1st or something. It was 2 to 4 million people in America. 2 to 4 million people dying in America. That got, of course, lowered down to, I can't remember the range, but it was basically 1 million to 2 million. And then with mitigation, so saying, all right, we're going to lock down the economy, we're going to do everything that these other countries are doing, we're going to do everything that we possibly can. So if you look at the pandemic response that the CDC has designed, not only this country, but all countries, there's only so many things that the individual can do. Right? Those are the non-pharmacological interventions, right? The NPIs that we've talked about before, things like washing your hands and wearing a mask and social distancing and closing down schools and closing down business. And so all the things that we're already doing, those are the things we can do during a pandemic. And so the decision was made to let's do everything. And then the modeling changed from there. It was, somewhere the upper number was around 600,000. And then Dr. Fauci came on later and said 100,000 to 200,000. Somebody else said 240,000. That got revised down to 80,000. That's since been revised down to 60,000. That number is probably going to go down yet again. The point of all that is that the modeling has been based for quite a while on doing what we're doing. Now, to be 100% frank and honest, we don't know that social distancing is helping. We suspect that it's helping, but we don't know to what extent it helps. So the reason the models have been so far off is because there's a lot of assumptions that have to go into a model. How contagious is it? How many people are susceptible to it? What's the death rate from it? How long does it live? Like, how long does it live viably on surfaces, which changes the contagion quotient, like how much of it, like how easy it is. There's something called the R naught. How many people will you spread it to? Is it airborne? Is it aerosolized? Like, is it? Do people respond to hydrochloroquine? Do people respond to ventilators? There's lots of things we're still figuring out, but the modeling makes a lot of assumptions about those things. So for instance, you can't make an assumption to say, 1 million people in New York City have the same risk of 1 million people in the Phoenix, Arizona area. That's obviously not true. There's lots of things that are different. There's different medical systems, like how many hospital beds, how many medical interventions are available to the general population, given, in a given area. And so per say 100,000 or per 1 million. So what's like, every area is different. So the city that I live in is not necessarily the same as the city that you live in. So what medical resources are available? I think we're done with the screen share here. Let me stop that. What medical interventions are available? What's the population density? So New York obviously has a very high population density. There's people living, and I think the majority of people in New York City live in apartment buildings. So they have people all around them. The streets are very congested. That like everything is tight relative to say where I live, Austin. Like we have a few apartment buildings, but most people live in houses. A lot of people live out in the suburbs with pretty big property, pretty large lots. What's the population density? What the medical system's like? What's the weather like? Does this have seasonality? We don't know if it has seasonality. It seems like it probably will have seasonality. That's based on the data we're seeing. We're suspecting there's seasonality. It doesn't mean that there will be seasonality, but there might be, meaning, is it going to go away because it gets hotter? Is it going to go away because people are out in the sun more? Again, we don't know. So there's lots of demographic sort of data that are going into these assumptions. There's lots of assumptions about the virus. But the good news is that it's all good news. It's all turning out to be significantly less. It's having a way, way lower death rate. The death rate that was first projected was somewhere, well, I think at the very beginning it was all the way up to 5% or something. And I think kind of once we really started focusing on it, once we started getting information besides China's, and getting more European, that I think we were saying between 1% and 3%. Now, again, that's nowhere near the most deadly virus out there, but that's significant. Germany's data is suggesting that somewhere over 1.3 or I'm sorry, 0.3 something, so round it to 0.4. It's still more deadly than the flu. But keep in mind, we have millions and millions of cases of the flu over the course of a flu season, and to have 50,000 deaths is a fairly average thing. So the modeling has done what modeling can do. The more information we have, the more data we have, and the more we can put into the better the assumptions we're making, the better the models will become. You have places like Sweden who aren't doing what we're doing. Their case load, their severity, again, demographics change, weather change, susceptibility, how young are people, how healthy are people. Lots of things go into that. Sweden has not turned out to be a ridiculous experiment. They didn't shut down the way we did. They're encouraging some minimization of group sizes and so forth. But we don't know. But the overall gestalt of it is this is turning out to be less severe than we thought it was going to be. Therefore, it is becoming something that is added to the risk profile of living in society. There are risks to living in society and living close to other people and working closely with other people. Those risks are, for most people and for the most part, those risks are outweighed by the benefit. So there's a risk benefit. There's a risk benefit to getting in your car and driving to work. There's a risk benefit to getting on a plane. There's a risk benefit to walking down a street late at night and when it's dark. Like there's always things that could kill you. There's a risk benefit to drinking alcohol, to taking any sort of drugs, all of these things. So overall, it's looking like it's not going to be anywhere close to the biggest risk that we're dealing with in our lives, which is good news. What we don't know is what we're doing mattering. If it is mattering, then what does it look like when we change? Because of course we have to change. We can't just stay home for a year or 18 months or however long it would take to develop a vaccine. And to bring that up, there's no guarantee we will have a vaccine. It seems likely, with the amount of resources we're tying into it and how important this seems to be to to the general population. Again, this doesn't have nearly the death rate of SARS or MERS. Those things are zoonotic, so that means they're usually transmitted from animals to humans, which is more rare. If the death rate is 0.3, that's about 3 times what the flu is. That could be really big if that gets added to the flu season. We have 30,000 deaths from the flu season and 90,000 deaths from coronavirus every year. That would be a really big swash, right? I mean, you're talking about we're at 120,000 instead of 30 to 50,000. That would be really big. We don't know that that's the case. Maybe nobody dies from influenza because they die from this instead, and the flu deaths during this, during next season are all coronavirus, and it still kills basically the same number of susceptible people. We don't know. But we do have to start having the conversation about how do we get back. So there's a lot of questions about that. Is there going to be a vaccine? Let's just assume there will be. If there is a vaccine that's developed today, it'll still take a year to get out because it has to go through testing. We have to make sure that it's safe. There are a lot of people who don't want to take a vaccine. So what happens if you don't want to take the vaccine? Well, does that mean you can't go to work? Does that mean you can't travel? Can you not go on airplanes? Can you not vote? Do you lose your birthday? Like, we don't know. What does that mean? There has to be some policy around that. Is everybody going to need to wear a mask? Is everybody going to need to wear gloves? Are we going to have to do social distancing at work? Like, there are lots of things that we don't actually know just yet. And we'll work on these things. But I think the way things are going, it's going to be much sooner than we had anticipated that we're going to start doing experiments. I've heard that Texas is going to be one of the first places because we aren't having a big spike yet. We have a lot of medical resources, and we have a large population, and we don't have a very high population density. So, we're going to do the experiment. We're going to figure out, but if we do that, does Texas have a big spike? If we do that, do Dallas and Houston and Austin have big spikes and use a lot of medical resources? And does it get scary? We'll find that out. But the data right now suggests that it's probably not going to happen. Do we all need to continue to stay home? That's a policy decision. I don't think there's medical data right now to suggest that that's true. But there's probably a lot of political pressure, especially being an election year, not to be political, but that's going to weigh into what type of policies get laid out there. Politicians are not mostly, by and large, politicians are not physicians. They're not epidemiologists. The epidemiologists, the academics that study this all of the time, they know a lot about this. They're very specific about what they think should happen. But other things have to be considered besides purely the medical aspect, the political aspect and economic impact. All of that stuff needs to be considered. Of course, there's a social, medical social or psychology, component of this that matters. I mean, people get depressed. People commit suicide when they're depressed. People die from drug overdoses when they're depressed. People have worse relationships at home, and there's more domestic violence, and there's more bad outcomes from that. These are all things that we have to keep in mind. But again, everything is looking promising that the smarter move and probably much more soon than we thought will be to start integrating certain populations back to certain jobs. We'll lower the threshold for what it means to be essential. Things like obviously trash service. I mean, my trash man just came today. There's the city services, there's UPS driving, of course, liquor stores. Those are essential. Need to get liquored up, maybe. I don't make the rules. But do we need to have masks? Do we need to wear gloves? Do we need to social distance? How many people go back? What do we consider essential? These are all things we're moving towards. But again, it's all good news. The death rate of this thing right now is very small, meaning you should not be worried about dying from this. You should not be worried about your grandparents or your parents dying from this. it's not relative to all other risk. It's not very big. New York City might be a different issue, right? There's a much higher population. They got into the isolation game later. Um, the and I've heard an epidemiologist talking about and tracking the virus phenotypes. So like, what does the virus look like? It slightly morphs over time. It looks like that New York's viral load, the big impact there was actually from Europe and not from China. Maybe why the West Coast doesn't seem to be having nearly the problems that the East Coast is having. Um, but at this point, it's definitely been around to a lot of places. And even though it's widespread across the country, and we know that there are cases of this in every state, I'm pretty sure, and I'm pretty sure we have deaths in every state at this point. So it is kind of everywhere already, but it's not the same intensity everywhere. And we don't know, is it seasonality that is causing this to decline in New York City? Is it just simply exhausting the number of people who are susceptible to dying from this? Is it some of the medical interventions that we're doing? Is it simply some sort of life cycle of this, and not that viruses live, but is it some sort of cyclic behavior of this virus that's causing it? Like, we don't really know why things are looking better, but the good news is things are looking better. I'd like to talk quickly about mask. The mask is a very political issue. I think every medical doctor that I know personally thinks that the blanket idea of everybody wearing a mask, especially homemade mask, is nothing short of silly. That's of course getting into politics, but I don't think there's sound medical and scientific data to say that is something that we know we should be doing. Definitely, if you're sick, if you're coughing and sneezing and all that other stuff, you should be wearing a mask. If you make a mask out of your t-shirt, I'm not sure that matters much at all. But we'll figure that out over time. But for now, I would say take heart. Realize that things are much better than they were saying they were going to be at the beginning. We have every reason to believe that New York is on its way down. The number of serious cases are decreasing rapidly. There's just not a huge number of serious cases growing throughout the United States, which means that we can't have a big growing death toll. Until we see an uptick in new cases and new and serious cases, and not so much new cases, because if we test 100 million people tomorrow, we're going to have a huge uptick in new cases, but we're a very, very small percentage of those would actually be hospitalized to serious patients. So if we look at the serious cases, it's not creeping up. It's not going super fast, or it is creeping up. It's not growing exponentially. It's not growing anywhere near the rate of testing. I think we said 700 new serious cases and 23 or 27,000, 23,000 new tests. That's not huge. And there's a severity bias. People that are getting tested right now, by and large, these are people who are sick. They're going in to seek urgent care and urgent and emergent care. So again, I'll say it one more time, take heart. Everything seems to be going in the right direction. The models were useful for caution. As we keep putting more information into the models, they'll get more accurate, but they're kind of working retrospectively. They're not doing a great job of predicting until we know a lot of what's happening. So the overall sense is that things are going better than anticipated, and we are working in the right direction. And I do believe that people will, restrictions are going to be lifted relatively soon, much sooner than a lot of people were saying at the beginning. There will be social experiments. The medical guidance is definitely, from everything I've read and the people I've talked to, the medical guidance is definitely, hey, we need to start getting society going again, and let's see what happens. We need to do antibody testing for anyone who's not aware of the difference. The test for COVID for SARS-2, this COVID-19 that we're currently dealing with, the test for that's what's called a PCR, polymerase chain reaction, where they're testing for genetic material from the virus being in your blood, or not in your blood, actually in your sputum. So they're doing a nasal swab and they're testing, and they're saying, do you have genetic information from the virus in your body? If so, we're saying you have a positive test. There's a lot of hoopla about how well are we counting the deaths, or anybody who dies with COVID is being labeled as somebody who died from COVID. That's a COVID death. All that will work itself out in the long run. But for now, it's a reasonable way of tracking, as long as we're doing it to everybody. It's something. There's some reliability to it. So if you're testing positive for the genetic material, that means you have an active infection and you have a certain viral load. So you could have, 50,000 viral particles in your bloodstream. You could have 500 million. You could have anything in between there. So, there's a viral load. The longer your body has been allowing your cells to be hijacked and used to replicate this virus, the higher the viral load, the more contagious you are. Once your immune system figures out the game, remember the antibodies are like strobe lights. The antibodies are sticking to these viral particles. They're putting strobe lights on there so that your immune system can come and fight it and kill off the virus and not replicate them. And then your viral load goes down to undetectable. We can no longer find that genetic information from the virus in you, but we can find the antibodies. And there's two different types of antibodies, but we don't. That's not really important. The antibodies that we want to find to say, well, you've had the virus, you no longer have the virus because you have this sort of long-term antibody in your bloodstream. You don't currently have any symptoms. To, I guess, fully test you, they would have to say they'd have to do both tests. But I think we're going to assume that if you don't have any symptoms and you have antibodies, then you've already had this. There's probably a significant amount of durable immunity, meaning that you're very unlikely to get the infection again in the relatively short future. And what that means, nobody really knows, but let's say for the next couple of years, it provides some immunity. But also, if you have antibodies and you've never had symptoms, that means if you get exposed to it again, you're not going to have symptoms again, almost certainly. So everything's going in the right direction. As far as the medical science, the death rate, it seems that we're on the downward slope. Of course, we will get spikes. We will get spikes in new cities. There might be a resurgence once if there is seasonality to it, that's usually to do with weather. So once things slow down and people start staying home more, like once the summer kind of comes and goes and people start staying home more and it gets colder and people are indoors more, will we have a resurgence? We don't know. We almost certainly won't have a vaccine by then. So there's lots of things to be considering. There's lots of things on the horizon, but it's going in the right direction. I think we'll see some return to normalcy relatively soon. What we all need to do is take really good care of ourselves so that when we do get the opportunity to go back out and test the relaxation of restrictions, we have the healthiest immune systems as possible. We've been sleeping well, we've been eating well, we've been mitigating our stress, and we've been exercising and staying active so that when we go out into the world again, we are as robust as we can possibly be. That's all I'm going to say for today. That was way more than I planned on saying. So hopefully that was helpful. Again, my only intention here is not to give medical advice. I'm not a virologist. I'm not an epidemiologist. I'm a physician that has an opinion. These are purely my opinions. I encourage you to do your own research. I reserve the right to be wrong about everything I'm saying. But so far, what I've been saying is kind of the way things are turning out. And I'm not saying I predicted anything. It was my hope that things were going to go the way they seem to be going right now. So I'll sign off for now. I will make a new one of these videos tomorrow or the next day. I know I said daily. I don't have that kind of discipline apparently. So we're try to get out at least 3 or 4 per week. All right, that's it.